patients who participate in remote transmissions overwhelmingly across the board do much better from a clinical perspective. So why should we not try our very hardest to do that for our patient population? Murj has helped us to do that.
Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform and optimize cardiovascular care for all. MedAxiom HeartTalk starts now.
This is Cheryl Toth, host of MedAxiom HeartTalk. COVID-19 has accelerated the shift toward delivering remote care and using digital platforms to monitor patients. We know many members have embraced telehealth visits, but what else can cardiovascular services providers do to monitor and care for patients outside the four walls of the clinic? To answer that question and discuss some of the innovative ways clinics are being redesigned for the future, we've invited two forward-thinking guests to the podcast. Joining us from Santa Cruz, California, is Todd Butka, founder and CEO of cardiac data device management software company Murj. Murj has developed a cloud-based device management platform that aggregates data streams from cardiac devices and provides a fast and effective way for it to be reviewed and managed by clinic staff. And calling in from Thibodaux, Louisiana, we have Jude Hebert, Executive Vice President of Nursing Services at Cardiovascular Institute of the South. The 60-plus physician group has been serving southern Louisiana for nearly 40 years and is known for such innovative remote and virtual care initiatives as Cardiac at Home and a 24/7 virtual care center. And we should mention that Jude is recovering from COVID-19, so you may hear some coughs and clearing of the throats during the recording. Jude and Todd, thank you so much for joining us on MedAxiom HeartTalk.
You're welcome. Pleasure to be here.
Yeah, thank you very much.
So Todd, let's start by having you give us a high-level description of cardiac device remote monitoring and what are its benefits for CV programs and care.
Yeah, no problem. And again, thank you for having me, and appreciate Jude's time, knowing he's recovering from COVID. It's a great opportunity for us and to spread the message about cardiac device management. From a high level, implantable cardiac devices are monitored roughly 31 and 90-day periods. So you can bring patients in office, but ideally, to get the vast benefit of remote patient monitoring and managing these devices, they're done remotely. They're done again on 31 and 90-day intervals. And the benefits have been validated from the variety of the device manufacturers over many years of studies that show improvements and reduction in all-cause hospitalizations, decreasing in mortality risks. So there's great benefit to managing these devices and managing them specifically remotely. And then if you really fast forward to today's environment with COVID, it also managing these devices remotely, keep your staff safe as well as your patients, because they can do this from home.
Yeah, it's very relevant in today's environment for sure. How does Murj, your platform, help CV programs do this, do achieve these benefits and do the remote monitoring? How does it work basically?
Yeah, the organizations, the majority of organizations we work with are what we would call self-governing, right? They have the staff, they just need better tools to help manage the population. Each of the vendors provides websites that you can log into, but when you can coalesce everything into a single platform and then create a workflow, soup to nuts, from a transmission being received to bills being dropped and anything in between that, routing it through the different care providers for review, knowing when something is billable or not. And then ultimately what we try to do is within 2 clicks, answer any questions somebody might have when they're looking at something. So as a care provider, if I receive something and I see something like VT, you typically want to know quickly, is this new? Is this old? If it's old, how many times has it happened and when? And is it the same or different than what's happened in the past? And so these remote transmissions come in mostly unscheduled, much like emails. They just randomly show up. And quickly, as a clinical provider, you need to coalesce. Did I bill for it? When did I bill last? Is this new? Is this old? So all those things, we essentially boil it down into a glance and a click to answer any of those questions.
Great. And Jude, your practice uses Murj, and you also you have a variety of virtual care services and use Murj for remote monitoring. Why don't you tell us a little bit about your various remote monitoring and virtual initiatives and the benefits that you're seeing at CAS?
Well, I guess historically speaking, probably about 5 years ago, our organization, Cardiovascular Institute of the South, started to engage in a strategy of providing virtual care to our patients in a multitude of different capacities. We felt that we have a significant growth strategy. Mm-hmm. We felt like providing care at home was the way that healthcare, in the direction that healthcare was headed. I think what we've seen over the last year is a supercharge of that concept with the pandemic that's happened. Mm-hmm. One of the things that we've always been interested in is how well and what would that do to our patient population. You know, the majority of our patient population is of Medicare age. And when you start talking about technology and virtual and this and that, you always run the risk of that population of patients, at least there's a fear that they won't participate in such measures. I think one thing that we proved is that that is not the case. Mm-hmm. The amount of, baby boomers and people above the age of 65 that are utilizing Facebook and other avenues of electronic communication, we thought that we could, introduce that into our environment and utilize that to have a better way of keeping track of our patient population instead of having this mass number of people walking through our doors every day. Mm-hmm. And so we've done several different things from a virtual perspective. We have a virtual Coumadin program. We have a virtual, basically, rhythm management department that does in-home telemetry monitoring. We do, obviously, remote checks with all our devices. We have about 9,000 patients that have implanted devices. We know very well that patients who are compliant with things like remote checks of their devices overall do significantly better. Mm-hmm. If we can show an improvement in quality and also with efficiency, then that's a win-win on both sides.
So I'm guessing that's one of the, you're mentioning 9,000 patients with implanted devices and the improvement in quality and the with checking in. Is that one of the reasons you chose to use Murj to support this? Tell us how you came to use them.
Yes, absolutely. We are always searching. I think, part of our mission statement is to provide our patients with the highest quality cardiovascular care available. And we have several different pledges that we do that by. And one of those pledges is technological superiority. And by utilizing technology, we feel that we have an advantage over our competitors. And that doesn't always come with it, very easily. You have to change culture when you do that. And what I mean by change culture is not only do you have to have the patients on board, but you have to have people within the organization, the providers, the clinical staff, et cetera, on board with utilizing technology to provide a superior service at a more efficient and reduced cost.
And let's talk about that for a second, Jude. First you, and then I'm interested in what Todd hears from other clients, but you talk about the culture change, and what do you hear from physicians and other providers as some of the biggest wins from remote monitoring?
Well, one of the big wins that our physicians repeat over and over is the fact that they feel that they have a better grasp on what is going on with their patient population. I think in the past, typically patients would show up to the emergency department and, they would end up having a interrogation in the emergency room, usually done by someone within the industry. And that information didn't always get to the provider. One of the advantages of Murj, as Todd was describing, is this ability to basically grab all of this information from all the different device manufacturing companies and put it into one platform that we can run analytics on, that we can keep very close track of whether our patients are compliant, whether our patients are having problems. There's a color-coded chart, color-coded data transmission that actually occurs. It makes it much more feasible for the provider to look at this data and make quick clinical decisions for the benefit of the patient.
All in one place where they didn't have that
all
before.
Correct.
Yeah.
All in one place.
Todd, what do you hear from other clients in terms of big wins that providers and physicians talk about?
I think one of the biggest wins that we see across our user base is the overall simplicity that we've been able to do through our design. That Chris Irving, our lead designer, was able to do. Visualization is critical to identifying where people are within monitoring periods. Again, like I referenced, like when I receive a transmission, clinicians need to look and think historically of, when did I get a previous transmission? When have I seen them last in office? When did this event last take place? Or is it a first time? There's a lot of questions that go through the mind. And then again, also can I bill for this? Can I not bill for this? When did I bill last? There's a lot there. And we joke about, we say dumpster diving in an EHR. Good luck finding that previous VT episode in a PDF somewhere buried in the EHR, right? So spending 20, 30 minutes of time coalescing all of that before one little transmission that should be, 2 minutes of your time. That is our goal, is to give people the tools to manage the patients. And most of our users have a high clinical aptitude. And we think the last thing they should be doing is thinking about, when did I schedule them, scheduling them again. All of that is built in the automation of the software. So take that administrative sort of burden off of their plate and focus on the clinical side.
This is all such a big change culturally. You mentioned that earlier, Jude, about the change, and it's kind of a whole new way of delivering care, this culture change. How did you get buy-in from the staff when you were moving in this direction as you started these virtual care initiatives over the last 5 years?
Well, that's a great question. And, one of the things I would tell you is, and I mentioned it earlier, is culture change. And I think you have to, as a leader, as a clinical leader, you have to have very candid and, descriptive discussions with the staff members as to why doing this work is so important for our patient population. And we at our organization preach over and over and over again that the reason we exist and what we do is to provide our patients with the highest quality cardiovascular care available. And that's our mission. And you have to get buy-in from the staff. And I will tell you that we do incentivize our staff. So it's, they look forward to an incentive on a quarterly basis. And that's one of the ways that you motivate them. But I would also say that getting to a point of making sure that you're capturing all of the data points on patients is a significant undertaking that everybody has to have buy-in with, from the physician to the patient to the clinical staff. At one time in history, our remote compliance rate was at 38%. Right now, our remote compliance rate is in the high 90 percentile.
Wow.
Having the ability to even measure that and understand where you need to go because of the overall outcomes that it affects with patients is what I talk about when I say culture change. Murj has helped us to do that.
Well, this is good stuff, and we're going to talk a little bit more about implementation and culture change and patient compliance, but I want to take a break, and we will be back in just a moment with Todd Butka and Jude Hebert. Stay with us. MedAxiom Academy offers online learning that makes educating your team convenient and easy. The 12-week course, the Cardiovascular APP's Essential Education Series, is structured to help APPs enhance the patient experience, onboard teams, and preserve profitability. Led by MedAxiom consultant Ginger Biesbrock and designed for new cardiovascular APPs as well as those who want to refresh their knowledge, this course offers a total of 31 CME credits. For more information and to register, go to medaxiom.com/academy. We're back on MedAxiom HeartTalk. We're talking today about remote monitoring and cardiac device data streams and how to make those efficient and how to get patient compliance. Jude, you were talking before the break about culture change and processes and making things more efficient. I want to have you think back a little bit to the implementation of Murj, and when you put new processes in place for remote monitoring and the Murj system, what were some of the most important learnings that you had as an organization that you might share with listeners who are thinking, gosh, we really need to do this. We need to make our data review more effective and efficient. What did you learn?
One of the things that we learned is how easy it was for the core people at Murj to come in to really understand and customize processes that fit our organization and our culture and implement those things to start to get data to transfer into the Murj dockets. That was one thing that I was very impressed with. These guys came in, they were able to, in a very short period of time, they were here for, 4 or 5 days, which we actually culminated with a crawfish ball that they enjoyed very much. But they were able to really take a process, grab data, work very well with our IT department, our EHR, get information flowing very quickly. That was quite impressive.
So let's hold on that one real quick because, Todd, that is high praise for a tech company. So often I've seen tech companies, they don't really understand the processes all that well. They know their software well. So what have you done to develop a team of people who can get in there, like Jude said, and really understand and customize the process for the program or the practice?
It starts from the very beginning of when we engage with an organization. We want to understand the needs, right? So we have a pretty high understanding before we even talk to the clinic what that clinic is doing, meaning what are they achieving to the standards of care, monitoring these patients. And then through the sales cycle, we uncover their workflow and gaps that we may be able to fill. Mm-hmm. And hopefully present to them an ROI that's compelling. And then we work like heck to make sure that we uphold our end of the bargain on the ROI. Because we're cloud-based, it's priced in a way that, people have the option to turn it off at any time. It's not that we're selling them a piece of software, taking the revenue and running and leaving it with them to install and implement. We handle all of that burden for the organizations that we work with. We pride ourselves. And if anybody on here is listening that's had, an Apple computer or an iPhone, If you buy a new iPhone, you pull it out of the box, click a button, and pretty much all your data starts to migrate. That's what I did in the first half of my career, was watch how something is designed and thought through in its simplicity, that this side of the business and healthcare was never, it just wasn't a part of it. So trying to bring that sort of Apple ethos into this world on simplicity, it can have significant impact to clinical efficiencies in patient care. And that's what we try to do.
That's terrific. So between the partnership throughout the sales and implementation process and the simplicity of the UI, that's great. And not every health tech application out there is like that, let's face it. So good on you. Jude, I'm curious what other learnings you had during the implementation that you said, we could have done this better, or this worked really well.
I think it's important for the listeners to understand, we felt like prior to Murj, we had very good processes in place to capture remote transmissions and in-office transmissions. But what we didn't have was a system that could make things more efficient. And what I mean by that was automation, meaning automate the billing process, automate and tag things in a category of low priority, medium priority, or high priority. We didn't have a system in place that could reduce our overall labor burden. And what we feared was as we continued to grow and we continued to have more and more implants and more transmissions, that we weren't going to continue to be able to operate on an economies to scale type perspective. And so the big attractant for us with Murj was the ability for that system to reduce our labor burden, automate processes, especially the billing component, and reduce our overall labor associated with everything that goes on in the remote and in-office transmission perspective.
So this is interesting. Would it be fair to say then that this learning is about the fact that you knew you were on this growth path and that your system needed to be more automated, but instead of trying to do that organically or recreate a system in your own organization, you decided to apply a technology that could do that for you, which is far more efficient than trying to just have more efficient human processes, isn't it?
Absolutely.
And what did you find when it came to the training piece of this, the staff education? What do you suggest to other nurse executives and administrators listening today? How might people optimize that?
Again, it goes back to having everybody on the same page through consistently communicating with them what the overall end game is and what the overall goals are, and getting that buy-in from your staff to understand how it may be a little difficult in the very beginning to learn a new process, but look 6 months from now to a year from now, look at all the things that this technology can do to make your life much easier and much more efficient and much more satisfying from a job perspective.
Todd, what do you suggest to customers who are training staff and meeting with some of that resistance? What kind of, do you offer the training? Do you do a train the trainer approach? How does that work in your implementation?
Yeah, I think a couple of points here. One is one of the most attractive things about working with an organization like CIS is that they are governing this, right? It's not a afterthought subspecialty clinic that's sitting in the corner. Nobody knows what's going on in it. It's actively managed, and when you have people ingrained in the process and wanting to see outcomes, embracing technology from the lowest level to the highest level of the organization, it gets embraced well. The rollout is super efficient. It's clicking on all cylinders. Versus, there are people that have been doing something a certain way for a number of years, and it's difficult to embrace something different, the different philosophies on how we might approach things. The one thing that's consistent is the fact that you're providing care for CIED patients. And so that's not far off from the same. But how you achieve that can be, and it can be disruptive. But the intent is not to so much disrupt versus just create more clinical efficiencies. And so if people can get open-minded about it versus thinking that I've been doing this the same way for 20 years and this way has always worked, again, when we look at the data and you're either 38% to the standard of care or you're 3 times the cost to achieve the standard of care, those are things we want to improve upon, and it takes change.
Well, and like Jude said, kind of keeping your eye on the prize 6 months from now, a year from now, after the training and the implementation, that's where you start to really see the benefits for the staff in terms of efficiency. And what about patient compliance? You touched on that, Jude, before the break. Tell us how did the staff talk with patients about it, and how did you achieve such a high rate? You mentioned 97% or something like that. You went
Right.
from 38% way up. How did you achieve that success with patients?
Well, several years ago, we basically systematically rearranged how we did things. And I would say that a large percentage of our patients were stuck on coming into the office for their device checks. And what we ended up doing was, and at that time, I want to also add that at that time, the majority of the device checks that were done in the office setting were done by people within the industry. So it was usually the device reps that were doing the actual interrogations in the office. Mm-hmm. Now, that limits you. That limits you with how much data they have access to. Their overall goal is to basically get the patient implanted. So we knew that fundamentally in the beginning we had to change that structure. So what we did was we employed and we trained, along with our EP physicians and our physician population, certain key members, on the ground members, which we term as device nurses. So now these device nurses became the ones that were face-to-face with the patients when they were coming in for their office checks. So from that point on, one of the things that we wanted to do was to have those patients start to show the patient population how easy it was to learn and get remote transmissions from home, make sure that they had the equipment at home, make sure that they understand the overall goal and how easy it was and why it could benefit them. And we began with this across-the-board strategy of what we call a 1 in 3 concept, meaning 1 in-office check annually and 3 remote checks for pacemakers and ICDs. Mm-hmm. And so that ground floor, face-to-face education from the device nurses, I believe, were the keys to how we changed the culture. So much that sometimes those device nurses were actually going to the hospitals and educating the patients at the time of their implants. I think that I've seen a study that was done that when you put that process in place, patients are much more likely to be compliant with remotes from the very beginning.
I think that's so well told, that story. I mean, there were so many good things in there that I took notes on. The 1 in 3, really packaging it for people so they understand that. The face-to-face device nurse contact and the education and the reiteration of the benefits, that is really quite a brilliant strategy.
Yeah. Real quick, Cheryl,
Yes.
one of the things that I find enjoyable is within our analytic tools and sort of the dashboard views, you can track your remote patient compliance, meaning what percentage of your population is being managed remotely. We work with several MedAxiom partners, and there's a good sized one that I've watched go from what was a 66% remote management in the last year and a half to I think right now they're around 79%. And you can see this, it's a slow transformation. You know, Jude would tell you probably it doesn't happen overnight, as he said, going from 39 to
Right.
Yeah, got to set those goals and keep at it.
But when you can see it and it organically track it, right? And watch that ticker move up, you can see month over month the penetration and the activity that your clinicians are doing to enable those patients to be remote, but also see them in office, but then have the visibility to see who's only seen in office and see that number go down, and or anybody that's inactive, like never been touched. Those simple tools to visualize that empower the clinic, and those are things I think we really get excited about, to see that adoption grow, and it's easy to do.
And you can run all kind of different analytic data on that patient population, which from a managerial perspective or an administrative perspective really helps you to project what revenue is going to be. It helps you to understand, you know, what future growth can happen. It also helps you to make sure that you're getting the dollars for the work that you're actually doing. So there's a lot of benefits to all of the different things that go into a platform like Murj.
This has been such an interesting conversation with both of you. Jude, I really appreciate your time today, especially as you're feeling under the weather as you recover. And Todd, you as well. Thank you for being here on MedAxiom HeartTalk. Appreciate all of your guidance and advice.
Thank you very much. It's been an honor.
Same here.
That wraps up this episode of MedAxiom HeartTalk. If you haven't yet subscribed to the podcast, please take 2 seconds and click our subscribe button on Apple, Google, or wherever you get your podcasts. And we hope that you'll consider giving us a review as well. If you prefer to give us feedback directly, send an email to hearttalk@medaxiom.com. And we hope you'll share MedAxiom HeartTalk with a friend or colleague. Thanks for listening.